Everybody, welcome to our live broadcast here, Town Hall about COVID-19 with Dr. Sanjay Udoshi. My name's John Daw. I am your moderator for this evening. So we're just going to get right into it here with Dr. Udoshi. And hello to all the other folks that have joined us tonight on the Zoom here. Just so everybody knows, we are both live streaming to Facebook Live and broadcasting on Zoom. So I've got like 4 screens in front of me here. Trying to keep up with it all. It's usually something we would do in studio with help, but we're improvising because of social distancing. So as Dr. Udoshi, Sanjay had said, we have taken a little bit more of an outline this week. And if you have questions, you are free to post that in the Zoom chat or in the Facebook live stream on Dr. Udoshi's page on Facebook. I know it's shared some other places, but when you click on the play, if you go to the actual page, that'll be sure that I'll see it. I will try to see it other places, but who knows? There's lots going on. So let's start tonight. I'm going to turn it over to Sanjay to give us just kind of an update on the latest numbers and news and where we are, and I'll send it over to you.
Okay, thank you, John. So I just really want to cover the basics of where we are in terms of numbers. So right now we're in the United States well over 550,000 confirmed cases. We have unfortunately lost over 24,000 Americans to the disease. Both those numbers are not necessarily accurate, and there are many reasons for that. One is we don't necessarily know how many people have contracted the disease and have an inability to or have not been tested. So there are many Americans that have actually suffered the disease and recovered, and we don't have any evidence of their disease at all. There are also a sad fact that a number of, especially in New York, a number of people have succumbed to the disease, died at home, and therefore are not being counted necessarily among the, the mortality rate that's being reported. We're nearing almost 2 million confirmed cases across the world. Right now, we are the hardest hit country with the highest number of losses to the disease. I have been able to make contact with physicians in the UK, in Italy, in Spain, in India, and am monitoring their experiences and how they're dealing with both being frontline physicians caring for these patients, as well as being public health officials. Every physician now is a public health official in their effort to monitor and report the disease trends and what they're seeing on the ground. So we have good news. Our major hotspot is the New York metropolitan area, and we are beginning to see leveling in the New York metropolitan area. We're also seeing very positive trends in California, and the West Coast, where many of the first cases were reported. And this is great news. It's due to the diligence of both the government bodies in the states that alerted their public and told them to stay home. It is working. Social distancing as a method is well known to produce these kinds of results. A rapid leveling and a rapid flattening of the curve, especially since we now know a lot more about how the virus is transmitted. We know a lot more about its latency period, as well as a little bit more about its infectivity. So the numbers are very heartening compared to 2 weeks ago in our second town hall. The weekend before our second town hall, the numbers were extremely disheartening. And so there's a lot to look forward to, a lot to be proud of, and a lot more to be careful about going forward in the next 2 weeks, so that we can continue to push this trend and continue to see these numbers decline. As with most statistics of this type, there's a lot of hidden numbers. If you see a peak in cases, in about 10 to 12 days, you will start to see a peak in the reporting of deaths. So this is just a harsh reality that they saw in New York. There is a trailing peak behind the peak that we see or will be seeing in confirmed cases. So far, this has been very difficult to really do the numbers and find out, how fatal this is as a disease. And right now, on average, it is about a 1.7 1.7% fatality rate, based on the most conservative estimates and based on some assumptions that a number of patients have died and not been attributed to COVID-19. The fatality rate could be higher, could be around 2.5%. We're going to only know the real fatality rate, what I would like better if we call it the mortality rate of this disease, in the next 3 months. And that's going to help us understand and create awareness, as well as preparedness for the next wave, which is inevitable. And so that's the news on numbers. Any questions on that before we keep going?
I have a question. Can I just ask it verbally, or should I chat?
Yeah, sure, please. Ask it verbally. This works great.
Oh, okay. So I guess my question around the mortality rate is, of course I like to tune and see what the other side is saying, and I've seen a lot of debate around the mortality rate on their side. And can you explain when they're claiming that people that are dying of things they were going to die anyway, and when someone passes away, how does the medical community go in and classify them as a person that died of a heart attack? Is it attributed to COVID? How does that parse out when someone passes away?
Okay, so that's a great question. Ultimately, the ideal way to attribute cause of death is what actually in the last 24 hours was the real root cause of their mortality, of their death. And the reason I like to use the term mortality is because it is a very well-defined term in public health and in hospital medicine. So that means the patient came to us with a presentation, we had an initial diagnosis, and then proceeded through the course of their disease. And then in the last 24 hours, our observation of their decline is really what led to their death. Okay, so we talked a little bit about this last week. There are many social determinants of health that are leading to certain communities being much more susceptible and having a much more detrimental course of their disease. Those with diabetes, those with hypertension, those with underlying autoimmune disease, and these are what we would call, very, very high risk factors for the most severe course of the disease, leading to high mortality. That being said, in a pandemic, you must err on the side of the initial diagnosis. So if the patient came to you with a high fever, with a cough, with the respiratory symptoms, then it is more than likely, it is highly likely that the cause of death is ultimately the infection, right? So unfortunately, not all hospitals, not all states are following a nationally standardized guidance on how to report the mortality of these patients. And so in some states, there's severe underreporting. I've been hearing this in Florida, I've been hearing this in Texas, that if the patient comes in and has a complication of their respiratory function or their cardiovascular function, and they had the pre-existing condition, then that's their cause of death, regardless of the infection. That doesn't make much sense, and it doesn't help us in the public health statistical realm to have that reported like that. Our preference and our hope would be that everybody reports on the same standards. We don't have those standards right now. So we don't have accurate data. You can't compare apples to oranges. You can't compare Florida data to Pennsylvania data because they're not reporting the same way.
Thank you. Interesting.
John, what's our next topic? I just wanted to.
Well, we're gonna toss this simulation up on the screen here, and you wanted to kind of talk about this dashboard from Johns Hopkins.
Sure. So this is the most accurate count that we have. It's a global database of reported cases by country, and then within the United States, we have reported cases by region. And you can see now we have now crossed 25,000 persons lost to this disease, and it is really difficult to look at that number and realize that 60 days ago that was 0. That is, that's 10 World Trade Centers in 60 days. And it's difficult to really absorb that. I have been getting reports from all over the country of people that I know, friends that have either contracted and recovered or have had actually family members die from this. And it is a horrible reality to go through, both if you are suffering it and also perhaps more so if you lose somebody from it. Globally, we have nearly 2 million infections. And as I said, we are the worst affected country in the world. If you look down here at the bottom, obviously you can see the number of tested is actually now 1% of the country has been tested. And that's great news. We got a long way to go. If you see the confirmed cases continue to rise, that trend will turn, but it's not going to turn, and it probably won't turn for another 2 weeks. However, if you go to the tab daily cases, you're fine right there, John. Go to daily cases in the large view. That's the good news. So you can see the daily case numbers have begun a downward trend. You will see spikes. There will be discrepancies. Not every day is going to result in a reduced number. The more testing availability that gets out there, we may see resurgence or flattening of that trend. But ultimately, the last 3 days or the first 3 days, we've seen a reduction. So there's good news there. So this is not very difficult to use. So if you guys wanted to access it yourself, we'll provide a link. The data on the right is really the most important data over here. Obviously those that have succumbed to the disease, we have to watch now the rate of recovery. This is also a very important number. We have right now a less than 10% recovery rate on a trailing 14-day average. So that makes sense. And then obviously the total tested, we want to see that number go up in leaps and bounds. and the more we test, the faster we test, the better it is, and we'll get into why that is the case soon. So the hospitalization rate is also very important. Now there's information on a local county by county basis that you can get regarding, your hospital utilization, ICU utilization rates. The good news is that all of the initial models were wrong. And the models change based on, instantaneous data. So day to day, the models didn't necessarily become more accurate. They actually showed that whatever was involved in mitigation has actually worked great. Sorry. So anyway, that's the numbers right now.
Okay. Let's see. And this one.
Okay, so this is local data for Pennsylvania. As you can see, Luzerne County, where I am, is a hotspot. Not great news, but we specifically have one town in our area that has very high traffic between the New York metro area, and that is the one that has been heavily affected. Because they don't have a major medical center in Hazleton, they're shipping them to Wilkes-Barre, which is where I am. So there's that. That's where John and I are.
Yep. Talk to us about ventilators, and what is so all over the news. There's questions about ventilators and moving them here and there and everywhere, and some people need them and some people don't, and in very high concentrated areas, triage doctors are having to make the call and who gets one and who doesn't. And how does the ventilator play into all of this?
Okay, sure. So again, 2 weeks ago, there was a huge fear that nationwide we wouldn't have enough ventilators. And the reason that was the case is that the ventilator is a very specific device used to assist a person whose breathing has become too difficult for them to do themselves, right? So we use them primarily in critical care or intensive care units. There aren't many in each hospital, and they're pretty expensive, highly calibrated machines. And what happens is that if you have a surge of patients that all of a sudden need ventilation, and the hospital only has 15 to 20, if you get 200 patients and 10% of them need ventilation, you're maxed out. So what happens next is, those ventilators are gone for 10 days, or at minimum 4 to 5 days, at maximum 17, 20, 25 days. So they get placed out of circulation. They are now dedicated to a single patient, and but you continue to have this flood of people that are trying to avail of the healthcare resources at that medical center. So you needed to have a reserve. You needed to have not just your 25 that are under active duty. You needed an additional 25 in reserve. And when those get used up, again, I mean, we saw this start to happen in New York City, but luckily there was enough deployment that they were able to handle the surge. And there were no reports of hospitals having to use one ventilator for 2 people, or that kind of stuff. That was really a very high fear factor that was pushed out by in the media. So what unfortunately did happen in Italy, because they were not afraid enough, they weren't thrown into a tizzy over how many they needed and things like that. they were overwhelmed. They were completely overwhelmed, and the period of time in which they were overwhelmed was about 5 to 8 days, especially in the northern regions. They where the disease was the worst. They were splitting ventilators and putting 2 patients or even 3 patients on one ventilator. And that's where our media got the news of that kind of potential requirement, and then the numbers started to come out that we were nearly 140,000 ventilators short in the United States if we had suffered the same kind of percentages of need that Italy had suffered. But maybe just in time, and specifically the lockdown of the states was the reason that we averted that disaster.
Any questions from anyone?
Terry has a comment. Cytokine Storm would be a great band name. I love it.
I have a question about ventilators.
Sure.
Sorry, I don't mean to hog all the questions, you guys.
Please, glad to have you.
I'm a healthcare organizer, so this is my thing.
Yeah.
So about ventilators. So I saw the other night that there was some kind of article, and in the article was a discussion about there's a threshold that doctors use to determine when someone needs to go on a ventilator.
Mm-hmm.
But there's a discussion around that COVID is acting differently, and maybe that threshold is kind of in question. Have you seen any talk about that?
Yes. Yes.
Okay.
So there's now evidence emerging that COVID is not the pneumonia that we saw initially that COVID causes is actually due to a different mechanism than we originally thought. So the first SARS epidemic from the first coronavirus had a very typical pattern of causing respiratory distress and then pneumonia. SARS-2 actually has a slightly different molecular pattern. And without getting into the technical details, when a person's pulse oximetry, which means the amount of oxygen sensed in their bloodstream through a device that shines light through your finger and kind of determines how much oxygen saturation is there, when that drops below 94% on room air, then we have to put you on supplemental oxygen. Okay. Then when that supplemental oxygen is unable to saturate your blood with enough oxygen that you continue to deteriorate. So you're on oxygen, but your bloodstream is not oxygenating because your lungs are filling up with fluid. That's an indication that we may need. This is an early warning that we may need to ventilate you. Okay. And not only ventilate you, there are other mechanical things that we need to do to mechanical and I would call it therapeutic things that we would need to do to start to get your lungs cleared of the fluid, as well as provide enough surface area within the lungs to allow the ventilation to be effective. So you'll see a lot of patients being turned prone, okay, and they're depending on their weight and other aspects, they will be inclined so that the maximum amount of the lung volume is then I'll just say it's dried out. It's not full of fluid because the gravity is pulling it. And as well, the ventilation is effective. So we're able to expand and contract your lungs using the mechanical ventilator. And then usually, like we're in a danger zone if it falls below between 86 and 90% on high flow oxygen. We want that ventilator to bring it up to above, again, 95% and make sure that you're getting appropriate oxygenation. Okay, all of that being said, ventilation has been typically the best way for us to support you in your recovery from the most severe course of the disease until your lungs are able to start doing that for themselves. Okay, and they're able to recover from that damage and the fluid influx. A number of physicians started to see that the patients with COVID-19 have a very typical, what we call pathognomic discrepancy or disturbance in their heme metabolism. In that the virus is not just attaching to or attacking the respiratory lining, it's also disturbing the immune response, which leads to the cytokine storm, but it's also disturbing heme metabolism, and it's causing the red blood cells to, the long and short of it, become inefficient. And it's also one of the main reasons it's so different from its predecessors. And there's a paper on this that was brought to my attention by a nurse friend, as well as, so there's just, we're getting information that our standard ventilation protocols need to be modified in the worst case of this, in the worst cases of this course of disease. So that's important, and we won't know exactly what we need to change, but we have to start gathering that evidence, because clearly there is something going on with these COVID-19 patients that's different, and it's not just it's not going to respond in its worst case patients. It's not going to respond positively to our standard of care when it comes to ventilation.
Thank you.
Let's take a quick break here, and I want to play a video that I shared last week from my dear friend, Dr. Rachel Levine, who is the Pennsylvania Secretary of Health. So give me 1 second to share sound as well. There we go. Here we go.
Now here are my daily reminders. Please wash your hands with soap and water for at least 20 seconds, or the time it takes to sing happy birthday twice. Use hand sanitizer if soap and water are not available. Cover any coughs or sneezes with your elbow, not with your hands, and try not to touch your face, especially at touching surfaces. Clean surfaces frequently. And if you are going out for life-sustaining activities, please wear a mask if you're going to come in contact with others. Practicing these everyday prevention measures can help slow the spread of the dangerous virus, COVID-19.
So let's see. So I have my gloves and my mask and a hand sanitizer and all sorts of stuff here. When do you think these restrictions will be relaxed? What are the most important ones? Are they all equally as important? Where do we go from here?
Okay, so restrictions. Right now, obviously, the most the most difficult restrictions to live with is the restrictions on our travel, the restrictions on being able to go out to eat and go out to shop and be able to move around. I would say the restrictions will start to be lifted probably by mid-May, especially as, and the good news is for those who have gone through the hell of being a hotspot. Those are the ones that will start to recover sooner rather than the ones that have remained untouched. Those that have remained untouched will have to be super or hyper vigilant for quite some time longer. But for those who have suffered the worst so far, those restrictions will probably start to get lifted by mid-May. I think that would be the responsible target time. You'll see businesses reopen. You will see people start to go out. But my hope is that when people do start to go out, and John just put up the accoutrement of the new normal, is that you realize that the bug isn't gone. And I'm going to take a pause here, and I want to cover the correct usage of this. I'll do this again at the end in terms of, you know, safety and taking care of yourself, and what I call being careful and not fearful. Gloves in almost all circumstances are not necessary. Okay, in almost all circumstances are not necessary. If you are germophobic and you feel an anxiety to go into a grocery store, or you're shopping for essential supplies, and you just feel safer with gloves, fine. But here are the rules when you're wearing gloves. Do not put them on at home. Do not drive with them on. When you get to the place that you're going, put them on. Go in, do your shopping with a list, and because that list is going to minimize your time of exposure in that area of high human traffic. Okay? Don't go in there and wander around and shop like, you know, like you usually would on you know, effortless shopping. Oh, let me just kind of see this and that. At least for the next couple of months, that's not a wise thing to do. When you are leaving that place that you're picking up your needed supplies, remove the gloves and throw them away immediately. Then use your portable hand sanitizer, okay? Because you will have touched the gloves to take them off, probably, and you will also have had, you know, the environment of that venue all over you. So use the hand sanitizer, because your hands are just naturally going to want to scratch this and touch that. And so even with after that environment, you want to make sure that you've used the hand sanitizer. Going in and out of your car now, you will have the bags, okay? You will have the bags, you will put them, hopefully you have a car. If you don't have a car, we'll discuss that. But if you have a car, you will put them in the trunk. Do not put the bags on the seats of your car. You're contaminating your seats, okay? Put them in the trunk of your car. When you get home, again, it depends if you're in a very high traffic area, for example, in a metro, okay? If you live in the Boston, Chicago, you know, New York, whatever area, and there are thousands of people going in and out of your grocery store or your Costco or whatever, these are the ultimately, you know, most vigilant precautions. Put your stuff in your trunk. All right, now you're going home. You're not driving with your gloves on, okay? You're not driving with the mask on. I'm going to go back to the mask after I get done with the gloves, okay? You're not driving with your mask on. And then you get home. It's probably a good idea not to bring the bags to a point where an area that you call a decontamination area, okay? Just, if you have to use chalk in your garage, mark it off and put all the bags in that area. Then bring your supplies into your home. If you, again, want to be hyper vigilant, then a Clorox soaked rag, or, you know, not soaked with Clorox, I mean a diluted form of Clorox, or Lysol or Clorox wipes, and then put them away in the fridge and the pantry. Okay. The bags then stay outside because they have been sitting in that store, in that environment for we don't know how long, right? So the bags stay outside or they get thrown away, whatever. Lysol that area and you're good to go. Now let's go back to the mask. So the mask, I've seen so many, and this is getting to the point of irritation, I've seen so many amateur infectious disease experts giving advice on how to use the mask. And so I actually asked a public health professional, infectious disease professional of 20 years about masks. And he said, Sanjay, the thing to remember is minimization and not, maximal protection. Maximal protection is everybody walking around in an N99 hazmat suit, okay, with a HEPA filter on their back and internal respirator and all this stuff. Okay, that's maximal protection. So I'm hearing people say, look, unless you're wearing an N95 or an N99, the mask is not doing you any good. That's stupid, because it's better, even a scarf with 4 layers around is better than nothing. So telling people that they're not protecting themselves unless they have an N95 or an N99 mask is counterproductive. Something is better than nothing. And the mask exists, the usage of the mask, or the guideline to use masks, exists for 2 reasons. And the most important reason is that we're getting evidence that the number of asymptomatic carriers of this disease may be in the 30 to 40%. Okay, so 30 to 40% of people are walking around and they're asymptomatic, and they actually may never show symptoms. Okay, they may have symptomatology as mild as a 2-day cough, and then they're fine. But they have a 17-day rise in viral titer and a 17-day decline in viral titer. 34 days, they are infective. I mean, they are able to transmit the disease, okay? So when we're asking everyone to use a mask, that means that these people who are asymptomatic and have a 34-day course of non-disease are going to the same grocery store and the same Costco and the same gas stations, and if they don't have a mask on, they're shedding. Okay, so everyone wears a mask, and then you are minimizing the spread of the disease from these asymptomatic carriers. If you're out in Costco and Wise or wherever, and you're coughing and you have a fever, one, you're an idiot, okay? And 2, again, this is going to actually minimize the spread of the disease, okay? Now, let's talk about the other way. So, is this protective? Okay, is a simple mask, a scarf wrapped around you twice, one of those, the ones that Terry and I have, which is kind of a ski mask type of thing, are they protective? So let me answer this question with simplicity, but with a little bit more detail.
My apologies. I couldn't hear what you said.
I have no idea who said that. Anyway, that was weird. Anyway, okay, so is it protective? It is not as protective as a N95 or an N99 mask, okay? A self-sewn, sewn-at-home mask, has the variability in the particulate filtration is so vast that I cannot say that it is protective, okay? But what does it do? It minimizes the amount of droplets that have the ability to land on your face, on your lips, on your nose, and enter your naso and oropharynx. It minimizes that, okay? So it is a good idea, all right? It is a great idea for everyone to wear a mask for the next 2 weeks to a month when they're out in public, because then we're going to minimize shedding from anyone and everyone, right? Now, in terms of protecting yourself, yes, it is so great idea in terms of the shedding, good idea in terms of protecting yourself. I hope that makes sense. Thank you, John. Okay. So great diagram, okay? You have an infected person, either symptomatic or asymptomatic, most likely asymptomatic. If you walk through the cloud of what they may have expectorated, either during speech, you're talking to them about, your family or your job, there are droplets that are exiting their mouth naturally. If you're in that cloud, the largest drops fall quickly, they dissipate quickly. The smallest ones hang out in the air, right? And if you're in that cloud without a mask, you can clearly see the result of that, all right? That's the short range route, droplet-borne or short range route. That's why mask of any type is one. Imagine if he had it on him, the red gentleman on the left here, if he had it on him, that whole cloud isn't exiting him as easily, right? if you have it on the gray gentleman, then the result is a less inhalation of those droplets. So then obviously the second route here in the middle here is called the fomite route, which is basically, so this guy's talking, it lands on the table at your Starbucks, and you come along and you touch the table when you go to pick up your Starbucks or whatever, it's now on your hands. All right, that's the fomite route. All right, and then obviously long range, the fear was, or the fear continues to be, that the virus can survive airborne, that it can hang out for 3 hours, 6 hours, 9 hours in the air in a space where an infected person used to be. So we don't know that. We don't know whether that is true or not at this point. So we err on the side of safety and say, everyone please wear a mask for now until we figure that out.
Okay. So here I am. Ignore. Okay. Wait.
Uh-oh. Is that me? No. Oh no, we lost our host. There
we go. So we can't transmit over the internet. So I'm okay. No internet transmission.
We are using Zoom.
Different type of virus, different computer virus. Okay. Becky wants to know that Becky is immunocompromised, and so what does that mean for her when things kind of start to get back to normal? Does she need to go longer? Is there once some of the restrictions lift?
Yes, absolutely. So for the immunocompromised and for those with risk factors, and I'm one of them, we have to be hypervigilant for longer. We have to be hypervigilant, especially in the next 3 to 6 weeks. Again, this virus over the next 3 to 6 weeks is going to find it much more and more difficult to continue to exist in the communities that are using these kinds of social distancing and barrier-based, protections. Protecting yourself is protecting others in your community. Let's basically say that. But for those of us who are susceptible to the worst course of disease, Becky and myself and others, and the elderly, we have to be hypervigilant for longer than normal people. If we find out that 50% of carriers are asymptomatic and then they seroconvert and they have an immunity to this first wave, that's great news. That means that the communities that have been exposed are going to have this herd immunity developing within them at a much faster rate than we previously thought. Not everybody has to go through the hell of the disease or wait 18 months for a vaccine. That, if we find out that asymptomatic carriers are developing this what we need to called herd immunity, that's great. That's great for me. That's great for Becky. But we still have to wear masks diligently. I in fact forgot my mask when I went to where did I go? Oh, to get pet food. So I got my pet food, and I was going to stop at Weiss, the grocery store, and I said, I'm not going in without a mask. So I put myself at risk just to go in to get the pet food because low traffic, in and out, one item, minimal, right? But I was going to be in an area with hundreds of people in and out, and I'm not going in there without a mask. So that's the kind of advice that I would give.
I want to come back to herd immunity in a minute, but we have another follow-up question. We've talked about high-risk people, and so could you, Karen's asking, could you review the top 4 or 5 risk factors such as diabetes, hypertension, asthma, people with those conditions? How worried should they be? How intense should they implement
Great.
some of the suggestions?
Sure. So I saw an elderly couple wearing masks diligently, well fitted correctly, wore it before they went in the store, wore it out, took it off before they got in their car. I was watching them, just like, in case I needed to step in and give unneeded advice or needed advice unwelcomed, whatever. I watched them and I was very proud. I wanted to go and tell them, very proud of you guys. So essentially, the high risk populations are the elderly, those above the age of 60 to 65. That population is actually two reasons. One is that population has a higher prevalence of heart disease, of long-standing diabetes, of long-standing hypertension. Okay, that's one. Number two, it's likely that there's something about their immune response that is either delayed or just because of age-based attrition of the immune system, they're at very high risk. Okay, so let's go back and cover these topics. Uncontrolled diabetes is high risk for everything, okay? Everything. So if you are not monitoring your blood glucose and not aware of whether your diabetes is controlled or not, you're putting yourself at greater risk, okay? So if you're diabetic, please get yourself, back into a program where you're well under control. The microangiopathy that goes with diabetes is very similar to that which happens in long-standing hypertension, in cardiovascular disease, in smokers, etc. We're talking about the capillary beds in your lungs, the ones that surround your alveoli. They are fragile in all of these diseases, okay? This is a different scenario for the autoimmune, and I'll cover the autoimmune disease in a moment. But so you have microangiopathies. These are just the fragility of these tiny capillaries that are in your lungs. And they are fragile and they are susceptible because of the disease. And then along comes this virus and takes advantage of the lung architecture, and bam, they get thrown into the worst course of disease before they even have a chance. Okay, it has nothing to do with the other aspects like heme metabolism or other things. It's really just a architecture, a physical thing with your blood vessels that's caused by diabetes. So please get it under control. Hypertensives, please get your hypertension under control. Take your medications every day. Check your blood pressure and be vigilant out in public. Cardiovascular disease. Smokers. Smokers do not have as active the cilia in their, the cilia that get rid of all of the debris and mucus from their respiratory system. That allows the virus to get in much more easily than it does in a healthy lung. All right. I hope that helps. Now, the autoimmune. Super complex, right? Super complex. The immune system, all of the different cells in the immune system, all of the different cell signaling, the complement system, the antibodies, B cells, T cells, etc. In autoimmune disease, there is a defect or disruption in the normal functioning of the immune system anyway. Along comes the virus, which then starts to mess with T cells, and it starts to mess with complement activation and all these other proteins that are in your bloodstream. You will again face a much more severe course of disease. So I could get into it, but it would take hours. So basically, it's already a bit deranged. I wouldn't use the word deranged. It's already a bit perturbed. And you may be taking medication that alters it even further or suppresses your immune response even further. So in that case, you're putting yourself at high risk if you're not being vigilant and in public, etc. And obviously, do not stop taking those medications. That's also very detrimental out of fear that they may cause you to have a worse course of disease. Please don't do that. Continue to take your medication, continue to be monitored by your physicians, follow the instructions. Asthma as well. Asthma is pretty much the same. As the hypertensives, you have a the architecture of the lung is disturbed in a way that it's very hard for you to clear, and the bronchioles go into spasm at very little provocation, and so the provocation of an infection makes your course of disease much more difficult to manage. Terry. So Terry said he heard from a very reliable source that it's a very smart virus. What was that? It's a genius. Wow.
All right. We want to talk about herd immunity in a second, but I want to show a quick video, give Sanjay and me a quick break from talking for a minute.
Okay.
And let's.
I want to take Kim's question after this. It's about children.
Okay.
Okay, go ahead.
Sure. Let me cue this up, and we will do this quick and come back in just a minute.
Virus that gets in you from whatever path, your body immediately sends up a signal and says, wait a minute, I need to battle this. And the cornerstone and the frontline battle against the virus is our body forming antibodies. One is for you to find out as an individual, did I have the virus, or was I exposed to the virus, and did my immune system mount a response? Two is, okay, oh my gosh, I have these antibodies. And that's where this army of scientists and experts across the country that we've been talking to are working on gathering those antibodies from you as a sort of a super donor, somebody who has formed antibodies that could help neutralize or treat, the virus in really sick patients. Another way is people who have antibodies, let's say if you have antibodies, theoretically, you could give those to somebody as passive immunity to prevent somebody else from getting infected. The antibody test is basically looking at your bloodstream. It's a blood test, and it finds out, has your body ever seen this virus? There are two tests kind of right now, a tube of blood that gets sent to a lab, or what we call a point of care test, where it could even be a finger prick with a little bit of blood, or still a tube of blood put into a little cartridge, kind of like a pregnancy test or a blood glucose test. I think in an ideal world, all the public health experts tell us that we should be doing both antibody and virus tests at the same time. We're just not in a situation where we can do that right now. We're just so limited on resources. So right now, we're dividing into two worlds, checking for virus, and you've heard so much about that, and then a new progressive world or an emerging world of checking for antibodies. The more people that can get an antibody test and we can see the results, the better idea we will know of how many people had the virus. Right now, the gatekeepers seem to be health departments. Some academic places are doing antibody tests because they want to try to use those antibodies for sick patients. So there is a website called ccpp19.org, and that's the Convalescent Plasma Project. And that's a conglomerate of about 40 institutions across the country that are trying to test people for antibodies to see if they can be used to help the sick people. Because this is such a new virus, we really don't know, do the antibodies that you formed actually provide you with immunity? We have hope, and we have history, and we have science that tells us that we'll be immune, but we don't know for sure.
Yeah, absolutely. Before I comment on that, let that simmer for a moment, because I do want to comment on that. I want to go over the mask. I didn't have the prop with me, so I went and got it while the video was playing. Okay, so your basic mask, right? You can get these. These are used in dental offices, medical offices, etc. You don't need the ones that are used in ICU and heavy-duty clinical environments. But this is good. So see how it's flat and it's a square, right? Don't put it on and leave it like this. Don't leave it like this. Okay? The reason it has pleats is so that you can do this. So first, high up on your nose, use the, whatever this thing is, I don't know what they call it, but it allows a metal wire in here to allow you to form it to your face. High up on your nose, right under your eyes. And then bring this down so that it forms a seal under your hair, okay? This is doing two things. Minimizing the amount of airflow that can go in and around, okay? Without being filtered by this material. The second thing is, now this is for Becky and me and others. So if you're gonna be in a grocery store for about half an hour, right? This is great, but this is going to start to get saturated with your droplets, all right? So the droplets then saturating this make it, attract other particles. So this is the secondary thing you want to do. A nice cloth cover, okay? This one is a little bit macabre, but Terry and I like it. So, right, and then what this will do is protect the mask from becoming overly saturated by particles this way and that way, all right? So you've got your cotton or whatever material, and then you've got this inner, now you have barrier that can be used for a good hour. And then when you go home, this comes off, well, not when you go home, when you get to your car, this comes off, okay? This gets thrown away before you get in your car, all right? You can be thrown in the wheel well or whatever. Take this and wash it and reuse. Okay? Okay, good time to cover kids. We may be seeing that these kids are not developing the infection for whatever reason, but maybe are asymptomatic carriers in mass. So that's great news and bad news. If now that schools are canceled, or most schools are canceled for the rest of the year, that's outstanding, because you can imagine these kids going to school and just sharing the infection with each other, not getting the disease, and then coming home and spreading it to their entire families. So there's one, another area of study that we need to investigate to see why children are not developing the disease. I'm extremely thankful that they're not, especially the full-blown disease that ends up with respiratory distress. But it may very well be that they are asymptomatic carriers, and maybe the bulk of asymptomatic carriers if we find out that they are. So that poses a risk to their grandparents and others that they come in contact with. So we do, now this brings me to the antibody testing. As soon as possible, the country needs to have access to these types of tests. Now, the cheap and dirty is the viral test for viral RNA that tells us that you've been exposed. Okay, so you've been exposed, and then you should be quarantined, self-quarantine, or just be away from people for at least 14 days. I would recommend at least 21 days, but 14 days minimum if you've tested positive, and you don't need to go directly to the hospital and wait outside the ICU. I mean, people have been made to think that they need to get in line for an ICU bed just because they tested positive. No, you just, if you're tested positive, then stay away from others and self-care. If you develop a fever, if you have difficulty breathing, then immediately call your hospital, your health authority, your doctor, and find a way to be monitored very, very carefully. I'm talking hour to hour. And if breathing becomes difficult, you need to get to the hospital immediately. At the first sign of it, don't wait an hour. Don't even wait an hour, okay? Antibody testing, so that's the viral testing. Antibody testing. The more we know about the whole seroconversion process, which I'll cover in a moment, and the picture of your community, what percentage of people in your community are immune to this first wave, meaning they have tested for the antibody against this first wave of the viral infection, the better, because then we are now the presence of that antibody in large numbers throughout your community, and people testing positive for the antibody is great news. Great news. So we need to have the availability of those tests, skyrocket, and everybody should start getting tested. There's plenty of money for all kinds of other things in this country, but this is the number one challenge for us to get back to business and get back to family and outings and sports and everything. That, we test for antibodies. We find out in Luzerne County, where John and I live, 40% of people are testing positive for antibody. That's awesome. We need to get it up to 60, 80%. And then we know in our communities, we have achieved herd immunity. We can start having sporting events. We can start having picnics, and we can open our businesses and things like that. I'm being overly simplistic, but that's the whole point of this antibody testing. Okay. Courtney, are they seeing any cardiac effects on the heart for those with underlying heart rhythm issues? So specifically, I have not seen anything in the literature. Again, I'm not a frontline practitioner. I'm a physician by training, and so I'm not out in the hospital environment. But I speak to, my colleagues that are on a daily basis since this whole thing started. And the two most important trends that we're seeing are involvement in heme metabolism and the difference between this kind of pneumonia and previous SARS or H1N1 or flu. It's different. There's something going on with the heme metabolism. There is evidence from France that there may be some cardiac involvement, but we don't specifically know what the cardiac involvement is, and it's only 15 patients that they've been able to see some dysrhythmia develop. But the other problem is we can't differentiate their dysrhythmia from anything that may have been underlying, because we don't know about what medications they are on long term. We don't know anything. So I wouldn't jump to any conclusions on the virus having a direct effect on cardiac tissue to the extent that it aggravates and exacerbates underlying cardiac dysrhythmia. Okay, but please do not take anything that you heard is prophylactic. When it comes to cardiac dysrhythmia, the number one biggest danger is the fact that there's this, what do you got to lose with hydroxychloroquine? Hydroxychloroquine is cardiotoxic. It's hepatotoxic. It can exacerbate, if not precipitate, a dysrhythmic storm, or even a dysrhythmia leading to sudden cardiac arrest. So stay away from anything that you've heard may help or be prophylactic. Just do not. Okay. All right. So thank you, John, for this. This is a very, very important way of understanding what a test is and why we do tests, and the problems that we've had with the initial set of tests. When we test, we have to be acutely aware of two things. Is the test sensitive? Is it specific? Okay. So sensitive, the ideal test result for a highly sensitive test, okay, is negative. All right. So that is, if I'm testing you to see if you've been exposed to the virus, the ideal test result is negative, right? But the problem with testing is that when a test is not sensitive enough, you will get false negatives, okay? To simplify, drive-up testing, nasal swab, negative, okay? Drives off into the community, goes home, and actually is carrying the virus, all right? That is a false negative due to a test that has poor sensitivity, all right? All right, specificity. Specificity is where we need, where the ideal outcome is positive, all right? It's telling us, yes, absolutely, no doubt, because of this antibody, we know that that this person has come in contact with this virus, okay? On a molecular basis, we know this is a highly specific test, and the positive result, okay, is telling us something, you know, that for sure positive test result, okay? So now you can see why we need to move from a test that's not sensitive enough to a test that's, you know, sensitive, but, you know, the real thing that we're looking for is specificity. We want to know that this patient, that this person not only was exposed, but actually recovered from and is now carrying the antibody. This is the goal now, all right? This is the goal for communities to start to feel safe. Recovery determined by antibody, all right? Which means that for the time being, for this first wave, this person is immune, is now immune, okay? Can somewhat fearlessly go back out to the community and realize that they're not going to contract this first wave of infection. This may not last to November, okay? This immunity may not last till November. It may not last till next summer. It may not last till 18 months from now, okay? They may be susceptible to a second wave of infection, to a viral strain variant that emerges in the later part of this year. But for now, they were exposed, they recovered, they're immune. John, where are we?
Okay, so you talked a little, you had mentioned hydroxychloroquine and other prophylactics. What medications are currently in trials and on the horizon?
Okay, great. So again, not to get too technical, but I want to again, I want to tip my hat to all of the thousands of researchers that worked on HIV for 2 decades that have given us the armament and the knowledge that we now have to tackle this problem. Without their work, we would be 2 decades behind this thing. Instead, we're 2 months ahead of it. We are 2 months ahead of it. We have the full genome of this virus. We know that there are 8 major strains out there. We know exactly what it looks like down to every strand of protein that it produces. And we know that because all of those technologies, all of that knowledge base came from us, came from the warriors that took on the fight against HIV. That being said, even some of the drugs that are being tested now are drugs that were originally engineered to tackle infections like HIV. And they include things like integrase and protease inhibitors. And again, I don't want to get technical. The point is this, that we have a class of drugs called protease inhibitors or checkpoint inhibitors. Okay, we'll just call them inhibitors. And what they do is they stop the virus on a molecular level from infecting their target cells. Okay, so these drugs are always end in the 3 letters VIR. So remdesivir, okay, favipiravir. All right, so these are antiviral drugs. They're specifically given in patients that have a viral disease, and they are now being trialed. Not only they're being trialed, they're actually showing great promise. All right, so we have that, and those papers again, and that kind of information we'll start putting out on John's helping me with a Facebook page. There'll be links to after this in the section where the video is going to be posted, etc. So all of that is great news. That we actually are well ahead of the game in terms of what kinds of medications are in our armament that we can actually now go out and trial and test. This is unheard of. This is unheard of, to come across a novel disease and already have, you already have arrows in the quiver, right? So that's great. What is not promising, okay? John used the word prophylaxis. Prophylaxis is obviously something you take before you go into an environment where you may be in contact with the disease or contract the disease. So prophylaxis for malaria has been traditionally known, by the name hydroxychloroquine, but it's known in this country by the trade name Plaquenil. Plaquenil is used in lupus. It's used in autoimmune disorders. And there was this very, very, very small experiment in France, 26 patients, 97% of them recovered because the doctor had placed them on hydroxychloroquine as well as azithromycin. And the thing he failed to mention until I read his paper 2 days ago is he also gave them ceftriaxone IV. I'm at a loss for words that he was taken seriously, and that he was that the president of the United States then said he has a good feeling about it. I'm at a loss to even, anyway. So do not listen to anyone that says that anything is a prophylaxis for this disease. The prophylaxis for this disease is knowledge, is safety, is taking care of yourself in public, is taking care of your family. That's the prophylaxis for this disease, okay, for this virus. There is no chemical, there is no plant, there is no crystal, there's nothing out there that in my allopathic study of medicine is a prophylaxis for this disease. All right, and I'm only one doctor, but I think if you ask 98 other doctors out of 100, they will agree with me. So things to be hopeful about is that if you get sick, 97% of you will recover with no long-term detriment. All right. If you have underlying conditions, like we discussed, the course of your disease is more likely to be difficult than not. The sad thing is that we've also heard extremely healthy, extremely people without any pre-existing risk factors have succumbed to the worst form of the course of this disease. 34-year-old marathon runner, 59-year-old weightlifter. I mean, people with outstanding cardiovascular health. So part of it is Russian roulette too. And that's why we minimize exposure. That's the best prophylaxis. We minimize exposure, we stay away from each other until the virus has nowhere else to go in the community but get flushed, away in the next rainstorm. So there's no guarantees with this. The percentages are in everybody's favor, but there is a very high risk that if they're not in your favor, that things can go badly. Yeah, very true. So it's a beautiful, picture from the end of the First World War. People grew sick of social distancing measures as they were asked to do at the onset of the Spanish flu in 1918. And they gathered to celebrate the war, the end of the war, and the second wave, which resulted from people just being jubilant and being around each other, ended up killing more people than the actual war. Yeah.
And there's a lot of conversation about a vaccine that's going to be here by last week, and then into 2022. So where are we at with that? What does that mean?
Okay,
What
so
can you
yes, the vaccines. All right, so we covered the drugs, we covered the tests. That's good. Covered a lot. Okay. Let me just finish up with, no, I won't leave those alone. We've covered up to prophylaxis. So we've done the tests, and now vaccines. Okay, vaccines. So vaccines,
And before you do that, I want to back up, and because we got a bunch of people watching this week that weren't with us last week. Talk to us about the development of the flu vaccine as well, because I thought that was really interesting about how there's so many things in one flu shot and how that works.
okay, so so you're going to hear a lot of terms in the news upcoming about antibodies, antigens, things like that, and it will get even more complicated over time, like things like monoclonal versus polyclonal, polyvalent, monovalent, etc. when it comes to vaccinations. So to simplify everything, I hope all of you get a flu shot every year, unless there's a reason for you not to, and there are reasons for you not to as well. But for those of you who do diligently get a flu shot, what you are getting is the latest digest, I would call it, of strains that we have been monitoring in the public health community, and we update that every year, and we update the vaccination with this digest of virus in order to keep the vaccine effective each year. Okay, so there are vaccines that you get in the early part of your life, measles, mumps, and rubella, and you'll get a booster, and then you have immunity conferred for the remainder of your life. And there are lots of reasons why certain vaccines can be effective for that long. I can cover that when we get to that, and maybe next week. But then there are some vaccines that need to be updated every year, and flu is one of those vaccines. Because what will happen with the influenza virus is a continual opportunity to mutate. So it infects in waves every year, flu season. Every wave of infection results in a new generation of the flu virus, and that virus then mutates and it divides into various strains. Some of the strains that are what we would call aggressive, persistent to the next year. The strains that are not aggressive, that don't infect as many people, they die off. And so when those strains die off, and we have a vaccine for those strains from last year, it's ineffective, right? There's no point in continuing to give a vaccine for a strain that is not going to infect people, but not include the vaccine in the vaccine the strain that is new, that is novel, and that is more aggressive. So you continually have to update these, and you can see on the screen that John's showing, that was showing you how over time, 2014, 2016, etc., we continually update and make the flu vaccine more and more effective. By monitoring the community spread, by monitoring what's going on, by monitoring the various strains and finding out which ones are the most aggressive, we can adapt and create the vaccine for the next year. All right, so coronavirus. 3 teams throughout the world that are spread throughout the world. Baylor University is one of them that was a major leader, as well as University of Pittsburgh, and also a team in Israel worked on the first SARS vaccine almost 11 years ago, 12 years ago. And then for about 7 years, starting in 2005 up until about 2012, they were able to develop a vaccine. They published results, they were ready to commercialize, and nobody wanted to develop it. There was no commercial demand. So we have a SARS-1 vaccine. Using the work from SARS-1, we can actually adapt it that work to SARS-2, to COVID-19. And so we will be able to rapidly, it's not going to take 7 years. It's going to take 12 to 18 months for us to, use that work, that understanding, and we adapt it for this virus and the 8 strains that we know that are out there right now. And then what will likely happen is, in order to continue to protect ourselves in the United States and Europe and Asia, we will have to share the information on which strains have been most aggressive. We will have to have very vigilant public health data collection and analysis, and we will have to collaborate on the creation of a SARS-2 vaccine that we can give throughout the world. As I said, and John, maybe you want to bring up the strain visual, because we could develop a vaccine for ourselves in the United States with the most prevalent SARS-2 strain, and then the Italian strain could come here and make that totally useless. So we have to collaborate globally on the development of a SARS vaccine, and the SARS vaccine will become, in my opinion, and speaking to other experts who have far more experience in infectious disease virology, it's likely going to be one of those things that we give yearly. It's going to be something that you get maybe now, right? You would get your flu vaccination in September, and you would get your SARS vaccination in January every year. And this is something that we update continually. We talk to public health around the world. We collaborate on it. We make sure that we keep it up to date every year. That's most likely what is going to happen. And maybe hit the radial view. Okay, and then hit play. Okay, now you can see this evolve from the Wuhan initial infection, how it divides. In fact, we have started to see that the American strain came to us from Europe and not from China. So genomically, we can determine that the strain that is ravaging the United States came to us from Europe. And this travels over time, and this genomic epidemiology will continue. This is beautiful. It took us 2 decades to do this with HIV, but now we're doing it in real time. Yay, science! Terry, when are you and I going to go throw garlic at 5G towers?
Any day now. I'm
when this is all
out.
over. When this is all over, I'll come down. We'll go throw garlic.
I'm getting a GIS map of all the 5G towers, so we're effective.
So yeah. So now we're going to be able to we'll be able to understand how this whole thing evolved and is going to continue to evolve, and then try to protect ourselves from it. Really, the only thing we need to be very wary of is make sure that we don't push a vaccine out that's dangerous, right? Or that's minimally effective. We want to do this right the first time, so that we protect the maximum amount of people for the maximum amount of time. Okay.
All right.
Social distancing.
We talk about social distancing.
There's a push for social distancing.
glad to see that you're practicing social distancing.
Yeah. One of the reasons, and I'm very thankful for John and his assistants, one of the reasons we're including these in the town hall today is that this gets recorded, and we are going to publish it for those who couldn't attend to watch it, and hopefully they are sharing it with others that will, get some education out of this.
All right. Any last minute questions? Go ahead and put them in the chat, or wave your hand or something, and we'll unmute you and you can jump on. Go ahead.
Is that Lou? Lou's with us. I see him now. And Becky, wonderful. Okay, I'm just scrolling through the videos on here. I mean, the video.
So I got a question, Sanjay.
Yes, go ahead.
All right, so herd immunity is 60%, right?
Minimum.
Minimum 60%. And we have had how many people infected in this country?
We have currently, almost, let's call it 600,000 confirmed cases. By tomorrow, it'll be 600,000, okay?
And that's what percentage of the overall population?
So that's less than, it's about 0.6%, 0.61%.
So this is going to dance around until either we A, have a vaccine, or B, hit 180 million
Yes.
infected.
Yes.
So the next year or so until this vaccine is prime, we're looking at social distancing, wearing masks. As soon as we let off of this is when we're going to get our second spike, right?
You very well could be. Yes, very well could be. So the other thing that we have to remember is that think of the threat of the virus as being it was very, very high in February, okay? With social distancing, the threat of the virus comes down, okay? Even though we need herd immunity, if we had herd immunity, right, the threat of the virus would have been very low. Because we had none, it's up here, right? So we will not have to survive with the threat of the virus at this level and then have to ramp up to 180 million, immune to it. By social distancing, and we're taking away the virus's opportunity to be a threat, to be a continued threat, with vigilance, over the next 3 months, if we continue this, if we continue to be vigilant and careful around each other, okay, then the threat of the virus finding an opportunity to become, what it was in early February, devastating, pandemic level of threat, that continues to decline. It will continue to decline. So we can get that threat level down while we ramp up our other efforts. Okay. So we don't need all of us to get up to, we don't need 180 infections and seroconversions. You know, we'll get that. Hopefully it goes like this. We've got that, 30 to 40% we find out have an asymptomatic, carriership and immunity conferred, 30 to 40%. And then we hold off this threat for as long as we can until the vaccine is available. And then, our herd immunity is conferred by the vaccine and not by 180 million people suffering with the disease, right?
Karen?
Hi, it's Karen from Wisconsin again.
Yes.
So Virginia just had 40 people die in a nursing facility, which is horrific.
Yeah.
So if a lot of these nursing facilities went on lockdown a couple weeks ago, so is it asymptomatic workers that could be carrying this
Yes.
in? Okay.
Absolutely.
So what is the theory around protecting these small environments? We can't even protect these.
Well, we can't see, the thing is, if we know that this is the case, we now have suffered the loss of these people. We should learn the lesson that nobody should be allowed near these communities without being tested. No one. I'm sorry if you work there and it's your livelihood, but it's their life. So if you work there, you should be allowed first in line to get the testing, because the workers there are absolutely critically important to those people, right, on the day-to-day basis, but they're also the number one threat to their lives.
Yeah, my daughter works in the kitchen of one, and they take the workers' temperature every day, but no one has been tested in her facility at all.
That's too late. Like if you show up at work and you've got a temperature, that means for the last 14 days you could have been infecting these people.
So basically, to sum it up, all of these facilities should be testing all of their workers,
Yes.
whether or not they have symptoms or not, and that's the only way we can protect these people.
Right. Obviously the first level of screening is to do the detection test to see if they're carrying. If they're carrying, they can't work there. Okay. They can't work there for at least 21 days, in my opinion. And then if they've seroconverted, obviously, if they've antibodies, then they can work there. Good to go, right?
Thank you very much.
Yeah. It's so great to see all of your faces. Thank you for joining us. Ask your friends to join us. If this thing could benefit from some advice on its format, or we should shorten things, or whatever you think we should do better, please let us know. John is working very hard on this, and usually gets paid for this. This is his area of expertise, but he's also a community activist and one of the best people I know. So I thank him for his work and effort as well. Thank you guys all for joining us, and let everybody know that we're going to continue to do this for as long as it's useful into the coming weeks.
All right, everyone. Thanks for joining us. We'll be back here next week. If you're watching on the live stream, you can always post your questions as a comment on the live stream, and we will answer them during the week. Dr. Doshi will check in on those during the week. Thank you, Sanjay. It's always great to spend some time with you. We'll be back next week. Have a great night.
Good night, guys. Take care.